There you go.
Thank you.
Thank you. Yeah, I felt for the mom, right? Because she really, and I've been in that situation. I don't know if anybody else has, but like you, I didn't hear the baby crying. You know what's going on. I thought Dad did a really nice job of trying to keep the mom, excuse me, to keep the mom calm. Yeah, the color change was nice. Yeah, I know somebody, if you read the comments on YouTube, if you can find the YouTube video, that was one of the comments, is that somebody was saying they felt really terrible for mom not getting to see the baby. And I don't know, the baby seemed, I mean, as stable as they could have been. I probably would have at least, excuse me, taken the baby over to mom. Those of you that have seen C-sections, right? They take the baby over. I'm thinking, yes. When you're at a C-section, right? Yeah. And so I don't think the mom necessarily could have held the baby because the baby needed to be on oxygen. But yeah, I think that was something they missed, is that they could probably, could have done a little better. And so you did talk a little bit. What else did you notice about what specific nursing care? Somebody mentioned, I think already, the suctioning. One of the comments on YouTube was, cover the baby's going to be cold. And somebody mentioned hypothermia. So maybe you can, you know, speak to that. The newborn assessment, right? Supplemental air. What was that? Oh, you couldn't hear. So let me figure out. So what happened is that, so the baby's born and they're giving her the stimulation and they're drying her, right? Rubbing the baby to stimulate and rubbing out the fluid, right? Because in a C-section, like in Monday's lecture, right, the liquid doesn't get squeezed out as well as in a vaginal birth. The mom actually had really bad pregnancy-induced hypertension, PIH, and they had started to, they gave her Cytotec the night before, and the baby didn't like it. The baby was having late D cells. So that's why they decided to do the C-section. And then, yeah, they were communicating. The nurses, not so much. I was kind of surprised by that. Dad was doing most of the communication with the mom. What gestation do you think the baby was based on what you saw? Anybody?
34 weeks.
Ooh, pretty close. Actually, 33 and 6/7.
Oh, nice.
So nice job, Liz. There you go. Yeah. And yes, I think a little SGA. She was 33 weeks, but I think she should have been at least almost 4 pounds. So yep, 33 and 6/7. And so initially they're trying to get her to cry. She really didn't want to cry a whole lot. They were suctioning, nasal suctioning. It wasn't a nasal cannula, or the nasal cannula, yeah, the NG tube. Somebody had written NG tube. So they were actually doing suction to get the secretions out. They're actually on the warming bed, right? You guys have seen the warming beds?
Yep.
Yes.
Yeah.
Yeah. Okay. So that's why they don't, because think now thermoregulation, right? You guys talked thermoregulation on Monday, right? So now we have a preemie, and they did cover her head, right? Once they kind of got her stabilized, because you lose the most heat from your head. And so they did do that. But she's on the warmer bed. So I'm not as concerned necessarily, because if you cover a baby in blankets on the warmer, then the warmer becomes ineffective.
Miss Salinger, one thing I noticed was that when they took the baby away from the surgery room, they just carried the baby to the next room. Is that protocol, or do they normally like put the baby in a bed and carry the baby out that way?
Not in this type of situation. Usually, I mean, I guess it would depend. I can't remember if it's Natividad. They have like a little window that they pass the baby through to the, excuse me, to the NICU.
Okay.
Excuse me, hold on a second. Post-nasal drip. They, because usually it's only a few steps away. The nurseries that I've worked in, it's like that. You just kind of, you pick the baby up. They're wrapped because you're going into a cold area, right? And then you go into the nursery. I thought it was interesting. I think those are family members that were in the hallway that were commenting, and they're, you know, laughing and crying and, oh, how tiny and how cute. What the nurses were saying, the nurse was giving report to the pediatrician or neonatologist that showed up, telling him about the pregnancy-induced hypertension and how that went. And then what else? And then we did the suction. We got her to cry. They were doing blow by. I don't know if you saw, they had the O2 tubing with the green end to it, kind of holding it by her face.
Yeah.
And that's what we would consider blow by, right? You hear that term blow by?
Yeah.
Yeah. And so that's what that was. And then they get her stabilized. Again, I thought Dad did a great job. And her name's Allie, but they were kind of making fun of the name in the video, which is what I didn't like. But eventually Dad came in and said, no, it's going to be Allie. And they're like, oh yeah, that's a nice name. But they're like Ali, Ailey, like it was really kind of weird. How many nurses did it take?
Lots.
It's like 4 or 5.
Yeah, 5.
Yeah, initially, yeah, right. And so you have the nurse that's drying, you had the nurse that was doing the bagging and then they get the baby into the nursery, and so they're getting the bed set together and doing the weight, right, and the length. She was 16 inches. And then they did the head circumference, and the head circumference was, what do you think the head circumference was? What would a normal, what would a normal head circumference, like a regular term
15.
baby?
Like 35
centimeters.
For the head circumference, like 35 centimeters. Length would be 18, 19 to 21 inches, somewhere in there. And then head circumference 35, 36. Her head circumference was 30 centimeters.
Oh, tiny.
Yeah, and why we continue to do length in inches and head circumference in centimeters, I have no idea. Okay, so let's go to the next one. And then they got her, I thought it was cute. Dad, how much do you think Dad thought the baby weighed? He was way off. But
Didn't he say like 5 something?
Yeah, he thought the baby was 5 pounds. And the nurses were kind of making fun of him, like, oh, you're wrong. Yeah, that's going to be a little bit off. But the baby was even tinier than what the nurses thought the baby was going to be. Because they were all guessing like 3 pounds, something. There we go. So now we're going to come to, let's see, what else I want to tell you. So we did that. Yeah, the nasal cannula, the nurse put the nasal cannula back on and kind of left it there. That was kind of, I mean, she fixed it eventually. They were nesting. Did you notice how they were making the nest? We call that nesting. So nurses like to do that different ways, but what does that provide for the baby?
Warmth.
Some warmth, comfort, right? It encloses, right? We were just all nice and cramped up inside mom, right? And then now we're out in the big world, and you can see how flared out, right? The legs and so we want to keep everything as midline as we can. So in thinking about a couple of concepts that we just talked about, what kind of nursing diagnoses, right? Hypothermia. Do we worry about hyperthermia in patients other than newborns? Ineffective airway clearance, nice. Yeah, low glucose, hypothermia. What other patient are we worried about for hyperthermia, or do we worry about that?
Elderly?
Yeah, for sure. I was thinking more along the lines of malignant hyperthermia. We talked about that last semester. Let's see, ineffective breathing pattern related to prematurity, evidenced by hyperstimulation to get the baby to cry. And they were actually pretty calm, I thought. Immature lungs, right? Hypoxia, good. Ineffective breathing pattern. I don't know if any of you could actually see her breathe. She had a little bit of retractions, but it was hard to see her breathe. She had a little bit of increased worker breathing. Hypoglycemia, yes, low birth weight. Oh, I love it. Grieving related to, I mean, I don't love it, but grieving related to loss of the perfect child. Exactly. Yeah, I'm not sure dad knows what they're in for. She, you know, she's going to be there a while. Risk for nippling immaturity, like for feeding, I guess, like being able to.
Yeah.
Yeah. Mm-hmm.
She may be so young that she can't. She
Right.
doesn't know how to eat yet.
Yeah, and so they'll have to do the yeah, because you've seen that in the NICU, right? And they're on the tube feedings. Failure to thrive, that's a potential. Sure. Yeah, skin injury. So the baby probably had the baby is what we call a little bit ruddy, I would think. But so there might be some you know, increased red blood cells. Are there other patients that we're looking at risk for skin injury? Are there other patients that we have altered nutrition? Yeah, the answer to that is yes, right? Because if you think across the lifespan, a lot of these things are, you know, across the lifespan, not just a baby or not just an elderly person. Hyperbilirubinemia, most definitely, for sure. Maternal anxiety, yeah, exactly. Yeah, I'm not sure. I don't know what they explained to her. That's not in the video, because usually you will explain to mom, you know, we have to, we're focusing on the baby and we want to get the baby stable. And so, you know, how long does it take to get the mom out of OR from a C-section? Generally speaking.
3 days?
No, from the OR, to go from OR to recovery or back to her room. Like an hour?
Yeah, like an hour and a half.
Like an hour. And so that's a long time to be, you know, or not know what's going on with the baby. That's really difficult. So hopefully you explain that to the mother. The dad gets to go with the baby. So that's nice. Oh, I like risk for intracranial hemorrhage. Nice. Impaired gastric and imbalanced nutrition. Yay. Ineffective tissue perfusion, risk for infection. Oh yes, we're going to talk about some of these things. Yay. I'm hoping that this is getting easier for you to fluid electrolyte imbalance, to come up with these kind of problems, right? Because they're going to repeat themselves. Let me stop sharing for a second and go open up the PowerPoint, and give me a second, and then we'll pick up from where we were. That's not what I want. That's what I want. So any questions from the video or what you saw? No?
So
Has anybody been to a high risk delivery?
I haven't, but my thing was, you know how we do simulations for different, you know, events that might occur?
Yeah.
The nurses, the way they do it, is it purely out of their, you know, experiences in nursing, or when you get into nursing and become a nurse at a hospital, do they give you time to go through a simulation like that?
So we do actually have a couple slides at the end of the presentation that talks about NRP, which is neonatal resuscitation. So you know how you have ACLS for adults, there's PALS for pediatrics, and there's NRP for neonates, which is 0 to 28 days. And so they actually, Stanford runs a couple courses that you can go to that are actually, simulations, and they tape it, and they, like we do, and do a debrief. And usually you'll send like nurses and the doctors and RCPs, you know, so you send a team to that. It's called CAPE. And then usually in the nurseries, I don't know if anybody's heard any talk of it, but we do run simulations on a regular basis. And when you are training, usually they want you to go through one as well, because it takes a while to get that proficient, because you're pretty scared the first time that it happens, you know, when you're at a high risk delivery like that. But yeah, they have training for sure.
Okay, thank you.
Yeah. What up? Anything else before I move on? No, we're good. Okay. So we're gonna objective number 8. We're gonna pick up from where Ms. Clark left off on Monday, and so explain how nurses can prevent infant abduction. What things are you seeing on your units, if you're seeing anything in the nursery that that can help to prevent infant abduction?
The ID bands on the infant and the mom match.
Yes. Yeah. And they did put ID bands on in the video. They had one they took to mom before the baby left OR, and then they were putting it on the baby after they weighed her. So yes. And there are actually like the baby sensors, there's sensors that you can get where the mom and baby match, right? So that if you would take the baby to the wrong mom, there would be an alarm, which I've never seen those in action, but that sounds kind of cool.
There's also the alarm bands they put on the baby so that if you cross the blue lines at the doorways, that they alarm the whole hospital.
Yes, exactly. And then it's usually a code pink or code A. Code pink, I think, is the most common one. And do you know what you would do if they called a code pink? What your responsibility as the nurse on the peds or NICU would be?
Stand in the doorway.
Yeah, close the doorways.
So I got stand in the doorway, close the doorways. What else?
Stay on the elevator.
Right. So what happens is they will call code pink overhead, right? And then what you're supposed to do is generally what I've seen happen is the nurses will go. You go in each room, and it's almost like the fire drill. And you mark the room that you've checked the room to see if the baby's in there or not. And then as you get to a room that has a mother and another baby, what you want to do, like, I don't think you want the mother and baby, all the other mother and babies to be together, right? Unless they're in the NICU, you can't do that. But say you had a well baby that was in the nursery or something, not the NICU, but the nursery, you would return them all to their mothers to pair them up and put a sticky or something on the door to say we've checked. And then everybody has a doorway or a hallway that they're monitoring. Security blocks the doors, and you're looking for suspicious, quote unquote, people. One of the other things, there's a picture here, some of my friends from CHOMP. The badge is actually light blue. And we used to have pink ones. And so anybody that's working, this is at CHOMP. I don't know about other hospitals necessarily, but that's how I know if they're wearing a pink or blue badge that that they belong in the NICU. Like if lab comes in, their name tag is white. But
SPMH, the nurses have a pink strip, and they tell the patients to sign a waiver that they're aware that only the nurses that have a pink strip are allowed to take the baby outside of the room. Anyone else is not allowed to take the baby out of the room, and they advise the parents to not really take the baby out of the room.
Correct.
And like the wheeling.
Right. So you're not allowed really to carry the baby out of the room. They don't even really want you to take the baby out in the crib either. They really want them in the room. So you don't leave the infant unattended. You know, anybody with a newborn near an exit or unusual part of the hospital. If a baby's being discharged from the hospital, how are they getting out of the hospital? Like, is mom carrying them? Do they put them in a car seat? What are you seeing?
When I had my baby, the nurse carried the car seat to the car, and she strapped it.
Okay.
And she went back in.
Okay.
When I had mine, I was wheeled out in a wheelchair holding the baby.
Right. Yeah, moms carried them out. Thank you, Desiree. And then what about the car seat, right? You guys talked about this earlier. Do we have anything to do with the car seat?
Not anymore.
Not
No.
anymore. No. And then the other thing, oops, I keep clicking in the wrong spot. Maybe not. Hold on. There we go. So teach the parent that the infant must be observed, position the crib away from the doorway. Here's a couple pictures of the different monitors. This is the one on the upper right is one that would go on the umbilical cord. Generally, I see them on the ankles. And something else that I thought was interesting was that teach the parents about being at home, like, because if you know how you put the stork in the front yard, things like that just tells somebody, hey, there's a baby here. So I thought that was sort of interesting advice. I'd never really thought about that. It's just scary to me to think that people would do that. Here's another picture. You were talking about the bands, so there have to be, you know, matching mom, usually mom and support person, which usually ends up being dad, but it could be grandma, could be somebody else, and the baby's bracelet. These are the monitors that mom and baby match. And then this is actually, which I've not seen, but I thought was pretty cool. I don't know if anybody else has seen it. They're doing the footprints. And so we usually do complementary footprints, but this actually gets scanned. And so there's a record of the baby's footprints.
Yeah, our nurse was saying that it's coming to our area, but we don't have this available in our area yet.
Okay. But I thought that was kind of clever. I like that. And then they also have at SVMH, I noticed, they have the cameras that go so the parents can see the baby. Is that what those cameras are?
Oh, in the NICU?
Yeah.
Yeah. So basically they put it overhead and the parent has a code and they can basically view their baby anytime.
Gotcha.
They want.
Yeah. And then this is just a little graphic of what the screen looks like at the machine, right? So if the alarm goes off, you can tell which room. You can also see where the baby is. It tags you so you know if the baby's in the room or not. I actually had one instance one night I was working, I was out, I don't know if you guys are familiar with Chomp, but we have the pond out there. So I was having my dinner break out there, like at 2, 3 in the morning. And I see this guy walking, starting to walk around I didn't notice him at first. And then I saw him starting to walk around the pond and he was carrying a baby. And I'm like, okay, this is kind of weird. And I'm like, cause they tell you don't necessarily approach the person, you know, depending on the situation, but let somebody know. Well, there was no way I could let anybody know really, because I was out by the pond. So I just kind of got up and in my own, you know, smiley, sparkly self, toned down for 3 in the morning, which isn't much. You know, I said, oh, hi, you know, I'm Shanine. I'm a nurse that works in the nursery. I see you're carrying the baby, you know, how's it going? You know, he's like, oh, great. We just had, you know, my wife is having some pain. And so I just thought I would take the baby and, you know, give her a break. And I said, oh, okay, this is your baby. And he's like, oh yeah. I'm like, well, I need to let you know that the baby, there's probably an alarm going off somewhere right now that the baby's not in the room. So if you wouldn't mind coming with me, let's start walking back to the nursery, to the, you know, mother baby floor. And just as we turn to start walking down the hallway, nurses are coming running down the hallway looking for the baby. And so, it was actually surreal. And actually mom didn't know that dad had taken the baby. Mom had finally fallen asleep. And so dad had just picked the baby up out of the crib and walked out of the room. But that room was at the end of the hall in a back corner. And so none of the nurses really saw him leave with the baby, but the alarm went off, which was a good thing. But I just thought that was the oddest thing.
Well, there goes her sleep.
Yeah, I know, right? Because what happens is somebody went to the room, is the baby in the room? And they woke mom up, where's the baby? And she's like, oh my gosh, I don't know, maybe dad, right? And the crib is there, right? And so it was really weird, but luckily the baby was safe, everything was fine. And we also do those drills in the hospital. So I think Skylar was asking about like resuscitation drills. We do abduction drills so that people know what to do as well. Okay, so we're going to talk about, let's see, we'll go a couple more minutes here and talk about maternal substance abuse. Has anybody been able to see or care for a baby that has neonatal abstinence syndrome?
No.
I know somebody that has. I don't know if Louis.
Miss
Yeah, there
Salinger.
you are, Louis. Thank
Yeah.
you. Yeah, Louis had that opportunity. So it's kind of a delicate situation. I want to focus on the baby, but know that the mom needs to, hopefully be getting some help. And it's really hard to not be judgmental in these types of situations, but everybody's different. But what I want to focus on is what the baby looks like and interventions that we can do for the baby. So, and Louis, you saw some of these things. Do you want to speak to what your baby looked like?
Yeah, I saw a lot of the hypertonicity,
Yeah,
right?
hypertonicity, yeah.
He had poor feedings. He was crying a lot, and he seemed very irritable. The nurse had a hard time feeding him and stuff, so that's what I mainly saw.
Was he jittery? I think he was a little jittery too.
Yeah, he was really jittery.
Yeah. And so jittery is a big thing, and it's almost like tremors. It's more than just little jitters. And especially if you're changing position or moving them, it's like a hypertonic reflex. And the sleep patterns are poor. They don't sleep very well. And they yawn a lot. And so it's really kind of sad. So what you have to do sometimes, what happens, and I think Louis, we had this happen, was that was mom positive for marijuana, but then it was
No, she for opioids, right?
Oh, that's right, opioids, yeah.
Yeah, she didn't want to admit it, but she did test positive for cannabis, and she tested positive for like opioids, but she wasn't willing to admit it until like later.
Right. So that was it. So we thought she smoked marijuana, but didn't tell us about the opioids. And
Right.
so, but the baby was acting like a baby that was withdrawing from opioids. And so then when they did the urine, it came back positive on the baby, right? Which is what led people to go back and question mom, I think.
Yeah. Exactly.
Yeah. And they sent the meconium. So you can do a urine drug test like you would for anyone, but with the babies, you can also take a meconium sample and send that off to be tested, because the meconium will hold on to whatever drugs were in the body. It will hold it longer than what urine would. And so it's almost kind of like an A1C for drugs. It tells you what's been going on in the past. So things that you'll see, excessive sucking, vomiting, diarrhea, nasal stuffiness, retractions, tachypnic a lot. So greater than 60, sometimes apnea as well. And so it's difficult to feed the baby. Sometimes they're on oxygen. They can't get any sleep, kind of like nursing school. Also, they might have a fever. They can be really hot. And normally babies don't sweat, but these babies, sometimes you will see some diaphoresis more in terms of like urinating, I guess, but sometimes you'll see a little sweat. The excoriation, so because they're, it's like they're constantly, like their skin is very fragile, but they're rubbing, like because they're so irritable, even though you swaddle them as best you can. It's just really kind of sad. And to note is that sometimes the baby doesn't even show any symptoms of the drug exposure or withdrawal, or you might not see it for a couple days. So if you have a term baby, and it's a 24, 48 hour thing, that you might not see anything at all. And if mom doesn't say anything, but the baby's withdrawing. And so some of the things that we can do, this link will take you to an article about marijuana use in pregnancy, because you'll hear people say, oh yeah, it's okay, I can smoke and the baby will be fine. But they're doing studies now there's studies that show that it can be detrimental to the baby. So this is just a little list that kind of tells you when you might expect to see onset of symptoms. So sometimes it's, you know, hours to weeks, could be, you know, 2 weeks barbiturates. So it's really kind of, I don't know, I think that's kind of sad personally. And then what we do, again, this will take you to a website that talks about neonatal abstinence syndrome. And what we use is a modified Finnegan score sheet. And so you can look that up online as well. But Louis, do you remember some of the things that were on that or things that you were looking for the scores, or do you remember what the scores were?
I don't know what the scores were, but I remember they were also using the Ballard score because they were unsure of the
Oh, the
baby's,
gestation,
like,
yeah.
gestational age, right? But I forgot
Right.
about the Finnegan score, but it was
Oh, it's okay. So it looks at, you know, how long do they sleep? Are they excessively sucking? What's their temperature? Is there, how much yawning do they do? You actually have to count the yawns for each hour. Is there diarrhea? Different things like that. And you get a numbered score. And then depending on what the score is, treatment can happen from there. So I think, so things that we can do, I'll get back to the scoring in a second, is, you know, as dark, you know, not bright lights, very clustered care. I would carry the baby around in the nursery. I'm not sure you're allowed to do that, you know, depending, but swaddling, you know, helping them to eat, and then having mom come as much as possible, which is difficult because most of these babies end up in the NICU because of that. So there's not that mother-baby bonding attachment opportunity as much. And I, you know, from the mom standpoint, you know, how would that feel to have to go to the NICU to take care of your baby? Oops, what happened there? Hold on one second. Why don't we take a 10-minute break, and I will pull that back up and we'll start talking about some respiratory things. Does that sound good?
Yep.
10 minutes? Yeah?
Yes.
Yeah.
Yes.
And then we'll finish up and move on to some other stuff. Why is that not? There we go. All right. People back? Some people back?
Yes.
Okay.
Yes.
So I'll take like 5 minutes unless we don't need it. Does anybody have questions about assignments or things that are coming up or? Right, because I know ATI was a big one, so we answered that one. We will put out some kind of focus area study guide for the final.
I have a question, Ms. Salinger.
Yeah, Juno.
It's about the ATI. So for the assignment, I think it was practice B or something.
Yeah.
Is it like something that we can take over and over again?
I think so, because you have to get 60% with the rationales off.
60% with the rational.
Yeah, it's the same thing that you guys did last semester, or it should be either exactly the same or pretty close to what you did. Nutrition was a little different because there's not as many practices, but, and then there's one assignment to upload the practice B, and then there's one assignment to upload quiz 1 and quiz 2.
Okay. And if we retake the test, does it change the questions? Because I figured, okay, I don't want to memorize questions. I want to learn questions.
That I don't know. No.
Questions are the same. They're in different order, but the questions are the same. If you take the same test over again.
Okay.
And the practice B would be the same questions?
I did it before the assignment. I did the 2016.
Oh, okay, yeah.
2016 one, and when I did my what do you call it, like the practice after, because I didn't do great, so then I did all those practices after, and then when I went back to take the test again, it was the same questions.
Okay.
So yes, the 2016s are open. If you want to practice on the 2016 practice A or B.
All right. I'll write that down so I have somewhere to review.
Okay, so the 2016s are for practice, but we're actually supposed to do the 2019s for submitting?
Correct.
Like 2016 and 2019? Okay.
Correct, yeah, you submit the 2019. But some people wanted extra practice, so I opened up the 2016s.
I have a question about the windshield presentation.
Oh, okay. I believe we're because what's the question?
Like
Remind me the
we're
question.
gonna have like a giant Zoom meeting and we're gonna like share the PowerPoint, or I was just wondering for like visual aids what I'm gonna have to bring to the table.
Gotcha. What do you
like
guys want to do?
I think a giant Zoom meeting would be efficient, and then we can just share our screen to if we have a PowerPoint.
Yeah, because the options would be a giant Zoom meeting. We could also do individual group Zoom meetings if you wanted to just present to Ms. Clark and myself. I think it's nice to, present to the class. We were considering maybe bringing, groups on campus, but I think that's going to be too much. So we have our meeting this afternoon at 3, and that's on the agenda to talk about how to do that. So, I mean, would a big Zoom meeting work for people? It'd be like this. It would have to be synchronous then. It would be in the time slot that it was originally planned for originally.
Yeah, it works for me.
I'm down.
Okay, yeah.
All
right.
And a Zoom meeting, is it possible like we can have it like timed? Because if we're doing a Zoom meeting, I don't know if everybody's going to be paying attention to their watches. So maybe we can incorporate something that's timed so everybody can get through it in a timely fashion.
Oh, yeah.
Some people talk less than others and some people talk more than others.
Yeah. I believe the time frame we set was 10 to 15 minutes. And I think there's 6 groups. Is that what you mean, Katrina? Like set like 10 or 15, know what your time?
Yeah. Well, I mean, because if we're doing it, it's different than if we're in a classroom, because we could obviously look up at the time and see and keep ourselves on track. But if we're like doing a Zoom, I don't have
I see what you're
time.
saying.
I don't have time on my laptop to look.
Gotcha.
Miss Clark likes to set her alarm to time people.
Okay. That's an idea. You sure? But I see what you're saying is because it'd be a group, right? And so like you'd be talking, and then when, you know, you guys would have to figure out, you know, maybe practice ahead of time. You know, Katrina has 2 minutes, the other person speaks for 2 or 3 minutes. How you know, however you were going to do that.
Yeah, okay. And then like you
Okay.
guys could throw up like a deuces to give us a 2-minute warning or something.
Yeah, or I like the alarm idea, because then it's, you just hear it, and then, or we can say 2 minutes. Yeah, something like that.
Yeah, okay.
Okay. Alrighty. So then moving on, the treatment. So neonatal abstinence can be treated with morphine. That's generally the drug of choice. And so the scoring that we were talking about, the excessive sucking, the fever, the diarrhea, if you have 3 consecutive scores greater than 8, then you would consider the morphine, the physician would consider the morphine therapy. Or if you have 2 consecutive scores greater than 12, you would consider going to the morphine therapy. So that's why it's important for the nurse to be doing these assessments, hopefully as objectively as possible, to make sure that that the care is being given. Having said that, scores can be all over the place because babies change from hour to hour. You're generally doing cluster care, so you do the score right before the next feeding. So that'd probably end up being about every 3 hours, every 3 to 4 hours, depending. And then there's an article here. The link will take you to the website. My American Nurse had an article actually from January of this year. And one of the new things that they're looking at doing is this new Eat, Sleep, Console scale. So I thought that was kind of interesting, based on eating and sleeping. So instead of looking at the respiratory rate and the fever and the diarrhea, it's looking basically at how much can they eat and how long do they sleep, and then gives you interventions that you can do from there. I've not seen this put into play yet, or I've actually had not heard of it, but I thought it kind of made sense. We can work on test questions later because there's a couple other things I would like you to do. So we're going to start talking about preterm. So this is a little preemie. That's a little preemie. So when you look at the picture, what do you see going on?
So he has an NG tube.
Mm-hmm.
So
Well, let's see.
That. Is that
I
an
can't tell if
NG?
that's an OG or an NG.
Whoever started IV on that little baby is amazing. What?
Yeah, thank you. Yeah, it's tough, but it can be done. We use like 26 gauge needles.
How about tourniquet? Do you guys use the same tourniquet, or is there a specialized tourniquet?
No, we cut them. We get rolls of the tourniquet material, and then we cut them in half so that they're smaller.
Oh, okay.
Yeah.
Yeah, I had a preemie who had a 24 and inserted, and I swore it was like a piece of like yarn. Like I'm like, oh, there's something underneath the tape, maybe like a piece of fabric, like a piece of yarn. And Dr. Castro was like, no, that's the actual, because he had a PICC line.
Oh, right.
And he's like, no, that's what it is. It's just super tiny, and it looked like nothing we've seen before. But
yeah,
I thought that was just amazing how they can get something that tiny that looks like nothing, and it's actually providing nutrients to the baby.
Yeah. So IV access, so fluid and electrolyte, right? That's actually a ET tube for hooked up to a ventilator, and then a feeding tube. And the baby's probably getting parenteral TPN, parenteral nutrition, lipids and TPN with electrolytes in it, because it's really difficult to feed to feed babies this little. This is teeny tiny. So preterm, born prior to 38 weeks. Your gestational assessment, you guys went over that already. Some of the things that you'll see, which we saw in the video. And actually, Jessica had a great idea about going back to watch the video on YouTube so that you could hear it better if you had difficulty hearing it. And so all these things are on the gestational age assessment. So we do also look, there's terminology for late preterm infants. So that would be a baby that's born between 34 and 36 and 6/7. And early term infants, babies born between 37 weeks and 38 and 6/7. So term is now considered 39 and 40 weeks. And then post-term, well, actually I take that back, 39, 40, 41 weeks. Those are considered term. Past that, 42 and on would be post-mature, and then less than that would be early term, late preterm, and then preterm, and then you've got your micro preemies, like your 26, 27, 28 week babies. And so things you think, oh, well, they're 36 weeks. That's generally kind of where you, I don't know if anybody's had a 36 weeker, but you're like, oh, well, they're really close. They should be okay. And 36 weekers are generally, pretty big. They're not too tiny. They're more on the normal length and head circumference, but they're immature inside. And so the problems that you're going to, right? So the problems you're going to see are potentially respiratory problems, thermoregulation problems, hypoglycemia, the jaundice, and feeding problems. So there were a lot of studies done years ago to figure out why these babies were having problems, and it's because they're not as mature. And then one of the other things is that some women were doing, or not, well, women and some doctors were scheduling elective C-sections for babies at 37 or 38 weeks. And it's too early, really, because even the early term infants can have these types of problems as well. So problems with respiration, a lot of this stuff we saw in the video. So that's one of the reasons I wanted to play the video ahead of time. So do you guys remember surfactant alveoli? I can't remember, I know we talked about it in my clinical group, but right, the surfactant to help expand the alveoli. Because what happens in the babies is that the sacs kind of get stuck together and you need surface tension. And so that's what the surfactant provides. It's hard for them, their muscles are weak. So a lot of times we'll actually put the babies prone because it's easier to breathe and helps with oxygenation. But you have to remember to teach the parents that not when they go home. When they go home with the baby, it's back to sleep. That we have the baby who's on a monitor and somebody's at the bedside 24/7. So here's some pictures on the left-hand side. So this is nasal cannula. This is an OG. It can be used for feeding, right, obviously, but it can also be used if the baby gets too much air in their stomach. It can be used to expel the air out. And the baby looks a little jaundiced, actually, right around the nose there. And then some of you, I think, have seen this machine on the right-hand side. In the NICU. And so this would be for supplemental oxygen. So it's hooked up to the wall with a blender, and then it gets humidified. And then, so what is this number in the white numbers there? What does that tell us?
How much air? That's the flow.
Yeah, the liter flow.
Yeah.
So that's not 20, it's 2. It's 2.
Sorry, I'm like 2.
Yeah, that's okay. Yeah, 2 liters.
Mm-hmm.
And then what is this 40 number telling us?
Is that the FIO? I can't see it.
Yes, FiO2. Yes. Thanks, Desiree. Yeah, because you were in the, Desiree was in the nursery this last week as well. And so the FiO2. And then do you guys know what the 37 is?
Temperature.
Temperature, right? So it's humidified and warmed. Yes. Nice. Okay. There we go. Thermoregulation, again, you guys covered that. Most of the babies, once the initial is under the warmer, right, which we saw in the video, and then generally speaking, they'll go into an isolette, which I think some of you in the NICU have seen those, and you set it at a particular temperature. You have a skin probe on the baby. The isolette will monitor the temperature. And you basically try to keep the baby in there as much as possible. Signs of thermoregulation. So remember, there's a correlation between hypoglycemia, low blood sugar, and thermoregulation, right? If the baby gets too cold, the blood sugar can drop as well. So this is a picture of modeling. Not modeling, mottling, right? So you can kind of see the color changes sort of in here as well. So that baby also looks a little jaundiced, is cold. So we don't want that. Is the baby going to shiver to let us know it's cold? No, they don't do that. So you want to keep the baby warm, have this neutral thermal environment. You would wrap them in the blankets with the hat. If they're in phototherapy though, then they have to be uncovered in order to receive the benefits of the phototherapy. So you might want to raise the temperature in the isolette if they're doing that. Now, one of the things to keep in mind with preemies, and it occurred to me with the students that were in the NICU this last week, is that too much stimulation is detrimental to the baby. Like sometimes just having a conversation by the isolette echoes and amplifies noises. And so even that can, you can have desaturations. That's how the baby's gonna tell you, hey, knock it off. They're gonna desat. And so trying to keep the noise to a minimum, and also how to interact with the baby. And one of the things I was thinking is that I know there's a set of twins in there, and they're kind of grower feeders at this point, not truly grower feeders because we're still watching some respiratory things, but they can handle a little bit of stimulation even though you're doing it's cluster care, right? Every three hours. But there's a couple babies in there, like the 28-weeker, and that might be why the nurses aren't having students do a lot of care necessarily with that baby, because too much stimulation is not good for the baby. And so it's kind of, cluster care, get in, get out kind of type thing. Here's a couple. So what's going to happen is they're going to shut down. Like they might have increased pulse and respiratory rate. Their color can change. They can become apneic. Sneezing's a big thing. They also can put their hand out like, leave me alone, stop. Excuse me. And a lot of times yawning. So these are a couple pictures. Like I love this one. He's like, in this one, they're like, no, just like back away, get away. And it's kind of interesting. They actually literally do that. And then this baby's in the prone position. He looks really comfortable. Yeah, he's got that IV. Hands are really good places to get IVs in babies, by the way, just in case you were wondering. And then the pulse ox is there. So I think that's one of the reasons why some of the nurses are like, no, I'm not going to have you feed the baby today, or, do some of the care with the baby, because it's really delicate care, and you have to have the expertise, like Skylar was saying about training, like to be able to read the cues if the feeding or the stimulation is too much for the baby. Feeding problems. So again, the coordination, suck and swallow, the position to feed. This is the side lying position here on the left. Well, it's supposed to be kind of side lying. Looks a little bit more like he's on his back, but side lying is a good position. And this would be a gavage feeding. So what's sort of the feeding protocol? How long should a feeding take for a baby in the NICU?
Um, 15 minutes.
Desiree says 30 minutes. She's on chat. So that's what I'm looking. Yeah, about 30
Oh,
minutes.
yeah.
Yeah, so like from start to finish. So they need to nipple in that time and then get the gavage feed in that time. And you need to be watching the baby. The nurses at SVMH put the gavage feeding up. They hang it on this little device so that they don't have to stand by the incubator with the door open, holding like in this picture here. But you still need to be with the baby. And this actually looks like that's an NG because there's the OG. That doesn't look orange. So that baby might have two tubes, one to get the, because they're on high flow nasal cannula. So one to expel the air and then another one for the feeding. And then there's also signs of readiness, signs of non-readiness. Do you guys use the feeding readiness? I don't think you do. I think you just feed every 3 hours in the NICU.
Yeah, it's just every 3 hours.
Every 3 hours. So sometimes for the like 30 weekers or younger, there's a scale based on this slide. And if they're not showing signs of readiness, then we just gavage. We don't even nipple them. But if they're showing signs of readiness, like the rooting, sucking, then we'll let them nipple for as long as they can tolerate it and then do the rest as a gavage feeding. Things that you'll see if they're having trouble during the feeding, because you're sitting there and you're watching the monitor and you're watching the baby, and you're watching the monitor, you're watching the baby. So if they desat, have a bradycardic episode, any choking, cyanosis, gagging, a lot of times the really little ones will fall asleep. Right, they'll go maybe 5 minutes, take maybe 5 mLs, and then fall asleep. So the goal is to get them to increase the feedings. And I think the feeding orders are like increase the amount of the feeding by like 2 mLs every other feed, something like that. So that you are because of the calorie need, because the baby needs the calories. And so you're trying to get the baby back to birth weight and then go from there to increase, to have them grow. So helping with breastfeeding, we've talked a lot about breastfeeding. I just wanted to show you, this mom's doing the hands-on pumping. She has one of those hands-free bra extension things to help with the pumping. And these moms need a lot of support. So hopefully lactation is providing that for them. They can do outpatient, although I'm not sure how they're working that right now, but we're doing a lot of telehealth conferences with the moms and the breastfeeding. And then here's some, this is a SNS supplemental feeder. So this is breast milk in here. And there's a tube that is taped onto mom, and the end of the tube, right, is at the nipple so that the baby can suck at the breast to provide stimulation for mom, but is also getting food as well at the same time. And then this is, I don't know if, has anybody seen this type of bottle?
No.
No? Because I don't think they use it at SVMH. We use it at CHOMP. It's actually, it's called a Haberman, and it's actually used for cleft palate babies. I think there's a slide of it in the cleft lip and palate lecture, actually. And it's a flow control bottle, which is nice. And then these are the milk fortifiers to add extra calories. This is the liquid Similac. Here's some powder. I don't like the powder. The liquid's better. This is an example of Prolacta. And can somebody tell me the difference between the Prolacta as a fortifier versus the Similac?
Is Prolacta the human based?
Yes. Yes. Breast milk. Yes. And what's the base for the Similac?
Cow milk.
Mm-hmm. Yeah. Right. And so the Prolacta, I think, is better. But look at you, Desiree. Desiree is on it. But how expensive is the Prolacta? Very. It's like $200.
Yep.
I mean, it's just ridiculous. But you can also, I think it's easier to figure out how many calories. So like the 24, 26, you can go up to 28 calories. I guess 30 even with the 10 plus. Which is amazing to me. So those are different options to still have breast milk and still, increase the calories to get the baby to grow. Okay. So this is a picture of the NICU. And we have, I was gonna actually have you guys do this, but I'll just do it. So what, can you guys see my cursor?
Yeah.
Yes.
Okay, so what is this baby in? What is this over here?
Isolate.
That's the isolate. So this is thermoregulation, right? And the temperature. And then what is this here? What are we monitoring with this device?
His vitals.
Yeah, exactly. You
And
are
is that blanket on top of the isolate, is that like a bilirubin blanket or like a Billy blanket or something like that?
No, that's actually to keep the to keep it kind of dark in there, so it's less distracting. So some facilities have actual isolate covers that actually cover the isolate, and other places just have big blankets that we can put over to keep it kind of dark and calm. Okay, and then so now we'll move over to this baby. So what's going on here? What do you guys see over here? What kind of bed is this versus this one? So this is a warming bed. This is the heater component up here. And then this will tell me the skin temperature on the baby. Right? And so why would this baby be here and this baby be here in the isolate?
It's like through the weaning process, right? Like
Yeah. Yeah, the level of the NICU is what Desiree is saying. Kind of what you're saying, Jerica, is this baby, my guess is more recently born and or younger, probably more premature perhaps than what this baby is, because we will try to stabilize under the warmer for a couple days if we need to, and then put them in the isolate. The other thing I'm trying to get you to do is look at, like, again, you're in the doorway, you're looking at your patient. What can I tell just by looking at the picture, right? And so what's over here? What's that?
Suction.
Yes, suction. So that's part of your safety check, right? You're going in, is my suction set up? Are my monitors set on the correct settings? Is my temperature where it needs to be? Is the baby warm enough? This is a ventilator, and this is the tubing, and here's some blue tubing here, so that tells me that the baby's receiving some ventilatory support. And this actually is what's called a syringe pump. It's different than what we've seen in peds. They use this in NICU a lot because you can do really small amounts on this, but that's another type of syringe pump. That's a lot going on. But that's kind of what, you know, when we talk about getting that snapshot picture, right? Does that make sense? Like, I'm hoping that's what you guys are doing when you, regardless of the patient, right, are looking at the patient to see what's going on, even if you don't know anything about the patient. So we're going to move on to RDS and retinopathy and all these initials, NEC. So RDS, respiratory distress. We've mentioned this a couple times about the surfactant and the immature lungs. And then this is, with respiratory distress, the thing that's scary is that the baby can initially look okay, like that baby that was in the video, because that baby wasn't grunting and didn't have big, you know, retractions. I don't know about the nasal flaring, but what happens is the baby can do fine, and then after a while they just tire out, and the lungs are, you know, working overtime, and you'll see the tachypnea. So this is like at a half hour after birth, and then they gave surfactant, so they were able to open up the alveoli. So this is that same baby at 3 hours, which I think is amazing. Surfactant is great. So CuroSurf is a brand name for surfactant. And then this actually is how it gets administered. So the baby has, this is actually suction catheter there, but there's a endotracheal tube going in, and this is the administration right here. So it goes directly into the lungs. Also, has anybody had a mom who was, or heard in report that the mom was given betamethasone?
Yes.
And why was that?
Basically, they gave it to the mom when baby was still in utero, and it's basically just to increase the baby's the surfactant in their lungs.
Right. It helped. Yeah. So yeah. Exactly. So that's good to know. If I know mom got betamethasone, then I might not be quite as worried. I'm still worried, but not quite as worried, because hopefully it did its job and will help. If the mom didn't receive betamethasone, then I'm going to expect different things. So we're looking at, hopefully, again, you're seeing some patterns here, right? But we're looking at the vitals. We're going to cluster care and decrease stimulation. You're going to have IV fluids, oxygen therapy. So you're looking at the pulse ox. You're looking at the supplemental oxygen and looking at the flow rates and the FiO2. And then we'll talk about retinopathy here in a second. Oh, look, the next slide. So retinopathy of prematurity, ROP. So this is a picture. This would be like a regular eye down here. And then with retinopathy, you get this overgrowth of the blood vessels, and eventually the retina can detach. So that's why that's a bad thing. We don't see this near as much as we used to. I think I was telling my clinical group that the babies used to be on 100% FiO2. So what's room air percent?
21.
21. So these babies were on 100%, right? The babies that you're seeing now are like on maybe 24. I mean, we saw 40 in that one picture, but not 100. But that's what was damaging the blood vessels in these early preemies, especially the little ones, 1,500 grams. And how many grams was the baby in the video? Like 1250 something, I can't remember, 1250, like small babies, right? So because we're able to blend the oxygen now and not have the big masks on, we have the nasal cannulas, excuse me, it's helping. And we're not seeing this near as much anymore. You would see it more in the micro preemies that needed oxygen therapy for a long time and at a higher concentration. So they might be like at 40%, whereas the babies you're seeing are on like 24% FiO2. And then this is necrotizing enterocolitis, NEC. So more initials, sorry. So this is an inflammation of the intestine, the bowel, that leads to necrosis. So the bowel actually dies. So you can have a diminished blood supply for different reasons. Bacteria comes in, the baby can get septic. And you get hypoxia or sepsis, so that's really bad. So this is actually part of the necrotic bowel there. This baby's very distended, and then this would show you the X-ray. But that's why we try to increase the feeds, in little increments, right? So it's 2 mLs every other feeding. And oftentimes the baby will be NPO, if they're preemie especially, they're NPO for a couple days or a day or two, and we'll run the TPN, right? The lipids and the electrolytes until they're a little more mature to where we feel the gut can handle some bacteria, because their immune system is immature as well. Does that make sense?
Is this why they measured the abdomen?
Yes.
In the NICU?
Yes, that is one. Yes.
Maybe during the first assessment, but I saw her, the nurse measure the abdomen.
So at least once a shift, potentially prior to each feeding.
Yes.
Yes, depending on how old the gestational age of the baby. Yes, because what we don't want to see is a large increase in the abdominal girth, because then there's some distension or there's something going on. So probably more than 2 or 3 centimeters you know, or actually visualizing the baby. But again, I've told some of you the story about the baby with the bowel issue that I had, and that abdominal girth, I think, had gone up 3 or 4 centimeters since the last time it was taken, which was 2 shifts prior. But yes, that is one of the reasons. Good idea there, Daniel. And so what I want to show you with this is that other things that you might see. So when you talk about bilious vomitus, it's more this greenish kind of color. And then you'll see bloody stools. And then this picture here, it's kind of subtle, but do you see these ridges here and here? Right? There's this kind of little ridge here and here. And then it's sort of distended around here. So that's bowel. Like you can actually see loops of bowel because it's inflamed, right? Because this is the rib cage up here, right? So these aren't ribs, this is bowel. Yes?
Yes.
Yes, thank you. And so if you see that, like NPO, call the doctor, that's an emergency. And so again, vitals, you're measuring the abdomen, you're listening for bowel sounds, and that's where it's important to listen to all 4 quadrants. And if you don't hear anything, listen for the 5 minutes each quadrant to see what you are hearing. And then you can also mark the loops of bowel. You can mark with a pen where they were, so you can see if they're getting bigger or smaller. And you're gonna make them NPO, and then hopefully resume the feeding at a very slow rate. Infection control is really important. Hopefully with antibiotics and things, it will resolve and they won't have to go in and take part of the bowel out and have ostomies and all that kind of thing. We don't want that. Any questions on those 3 things? No, okay. So that segues into infection and sepsis in the newborn. Has anybody had a newborn that was septic? Or I'm sure most of them have all been on antibiotics at some point. No, nobody's had a septic baby? Good, I'm glad.
No.
No, that's okay, because it's scary. It can be scary. And I think I told, I was telling one of my groups, one of the other babies that had a bowel perforation, like you could see the baby become septic, like the color change and the respiratory status. That was really, really scary. So you can have organisms that cross the placenta during labor. Bacteria can ascend and get to the baby. You know, family members, caregivers, contaminated equipment, bacteria that can also get into the baby's system. And you can see it immediately sometimes, and then sometimes it'll be late onset, depending on the organism or what's going on in the particular situation. So risk factors, that's one of the reasons why when you give report, we want to know the mom's GBS status, right? Her beta strep status. Because if mom's positive, then potential for baby to have an infection increases. Have you had moms taking care of moms with chorioamnionitis?
No.
No, somebody has. I know I heard somebody say, yeah?
Yeah.
Yeah, and was she on antibiotics?
Yes, amoxicillin and gentamicin.
Okay, might be. And so if we know that the mom has chorio, we're going to start her on antibiotics right away and hope that those antibiotics cross over to be prophylactic for the baby. Long labor, prematurity, and then what about increased length of rupture of membranes? What's like is there a cutoff that we're worried about that would increase sepsis for the baby?
Is it 24 hours?
So 24 hours is yes and no. So 24 hours is sort of the rule of thumb, but we've even gone down to 18 hours, like start antibiotics at 18 hours, depending on how the labor's progressing, because they found that that helps to start the antibiotics earlier. So signs of sepsis, things that you would know, I kind of put those in red. Those are kind of the things that you would see that would be like, oh, okay. So cold, you know, thermoregulation issues. One of the key things, and you guys, I'm hoping, I wish this for you moving forward and everything you do nursing wise, is that you get this feeling that the infant isn't doing well, right? You look at the baby, or you've been taking care of this baby for a couple of days, and you come in and you go, something's not right. Color's different, they're distended, something just doesn't feel right. And I will tell you 9 out of 10 times the nurse is right. And that's where that advocating for the patient thing comes in, right? To really advocate for the baby to do what you think, you know, in the S-bar, what your recommendation is. You'll see nasal flaring, the grunting. So this may be a baby that's been breathing fine, and then all of a sudden is having difficulty with the grunting. The flaring could be apnea, tachypnea, and the color will change. So there can be some cyanosis. What you'll see is the pallor and mottling, it's almost pale, but it sort of can turn to a sort of yellowish grayish color. I couldn't really find a good picture of it to show you. And hypotension is a big thing, but if I'm looking at the baby and they're cold and they're having trouble breathing and there's color changes, then I'm worried. And then also what you might see in the GI system, they might be vomiting or have diarrhea. Remember in the NG feedings, right, we check residuals. Remember that? We would check placement, but then we also check to see how much of the feeding is left.
Yes.
Yes. And so that's another reason, because if the gut isn't working and not digesting the food, that could be a problem. So again, the abdominal distension, hypoglycemia, and then the central nervous system, the decreased muscle tone. So the baby will become kind of floppy and lethargy. So a baby that was somewhat awake and responsive, now you can't wake them up hardly, or it's very difficult to wake them up. Or if it's more of like some increased intracranial pressure along with it, then you might see the fontanelle, the bulging fontanelle, the high-pitched cry, the irritability. But the babies generally that I see, it's like their system just shuts down to try and fight the infection, of which they don't have a great immune system to do. And so a lot of times it'll be the baby was, you know, looking pretty good, looking okay. And then now you look and it's like there's this change. So that's why I will tell you to get your baseline, to look at the baby, to look at your patient as soon as you can, so that if there's a change, you know what it is. And so they're going to do, they're going to draw blood, and they're going to draw blood before they do what?
Administer antibiotics.
Thank you. Yay, right? So you're always going to do the culture before you administer the antibiotics. Now, having said that, you've already called pharmacy and have the antibiotics at the bedside waiting for lab to come and draw the cultures. But you're going to see an increase in bands, the immature neutrophils. Why would you have decreased neutrophils and increased immature baby neutrophils?
Because the neutrophils are already trying to fight off the infection, and your body is making new neutrophils, which is why you have more immature neutrophils. Exactly.
Yes, because the neutrophils are fighting the infection as best they can. And then CRP, right? What is that indicative of in babies potentially? Inflammation, which could be significant for infection, right? X-rays potentially, the blood glucose. So the blood glucose is generally going to be low, but once the body gets into stress mode, could potentially be high. And so basically supportive measures support the breathing, support feeding if it's indicated, the antibiotics. What kind of antibiotics would you expect to see with infants, with neonates? We've given them on the floor.
Gentamicin.
Gentamicin, yep.
Vanco.
Vanco.
Yeah, maybe Vanco's not quite, well, yeah, I guess so. Yeah, gentamicin and the ampicillin. And then when you, when you get the cultures back, if you need to switch up. Cefazolin, maybe. Okay. So any questions on teeny tiny preemie, GI, respiratory? Right, we're still looking at respiratory, we're still looking at GI, we're still looking at skin, right? Just in a little different way. Yes?
Yes.
Yes.
Thank you. Okay, so now we're gonna move on and talk about post-maturity syndrome. So babies that are born overcooked, not underdone. So this is just to put it in perspective. This would be a picture of a 28, less than 28 week preemie, right? We've just spent time looking at that. This would be your term newborn there. And then they're showing you the feet, because what is important about feet? Yes, the creases, right?
Yeah.
And so these creases, when it says upper 2/3 of the creases of the foot, that's what that looks like, right? There's not many creases here, but you can see some creases up top there, right? That's what, and then this baby who's full term has creases on the whole foot, right? So that's part of that gestational age assessment. And then if you look at the post-mature, so more than 42 weeks, so there's lots of vernix and the feet are peeling. That's what that's trying to show you, is the peeling, and here is peeling of the skin and lots of vernix. So here's another picture of the post-term feet. So born beyond 42 weeks gestation. And so what happens is you get an old placenta, right? And what's the function of the placenta?
Blood, supply, and oxygen.
Nutrients, oxygenation.
Yeah, all the above. Yes. And so when the placenta gets old, then that doesn't happen as well anymore. So you get the fetal distress. Actually, you can have a higher mortality rate because, again, like the preterm baby where we thought, oh, they should be fine. Oh, well, they're 42 weeks. Yeah, for sure they're going to be fine. But they actually have their own set of issues as well. So things that you can see, because the baby's been in utero so long, oftentimes they're stressed. And when the baby's stressed, what happens? Baby's stressed in utero.
They poop.
They poop. Thank you. Yes. And so they're swimming around in meconium, so they can have meconium staining. They can have meconium aspiration when they're born because they're, swimming in the poop and it's coming out. They don't necessarily feed all that well. They could potentially, if the baby's bigger, there's a higher potential when they're delivered to have shoulder dystocia. Right? We see that in some of the diabetic babies. These babies can be large like the diabetic babies. And the cracked peeling skin, they have trouble breathing sometimes. Hypoglycemia because they're bigger. They use up the sugar faster, and it's difficult for them to regulate their temperature as well. So look at that list, right? That's like the same list that we had for the late term preemie, right? So it's the same things that you're looking for. Isn't that nice? It's not a new list of things to learn. Yay. So I'm not going to go into that because it's the same things, just to realize that post-term babies can have issues as well. Okay, now we're going to look at the LGA, SGA babies. So I got this picture a couple years ago. It's a woman gave birth to a 13-pound baby by spontaneous vaginal delivery.
Oh, wow.
Whoa.
Yeah.
What?
Yeah. Yeah.
Ow.
Ow. Thank you. Yes. And then over here is this baby. So this is a term baby. This baby here is 37 6/7. So just early term, but 4 pounds, 14 ounces. Right. So there's their little sensor. They've got their monitors on, cord clamp. They're in an isolette. They've got a feeding tube in, right? So yeah, so this would be LGA and this would be SGA on the right-hand side. And we use a scale similar to this when we're looking at when you're looking at the weight, we also were looking at like hypoglycemia, hyperglycemia. So if you're appropriate based on the weight and how many weeks gestation you are, then you're in this part. So the baby in the video was 33 weeks, right? And what did we say? I think 1250 something. So like she's kind of, nope, she's actually right over there. Right? Because what did I say? Didn't I say I thought the baby should weigh maybe closer to 4 pounds?
Yeah.
Yes.
If anybody was paying attention, yes, thank you. And so that puts her small for gestational age. Does that make sense?
Yes.
Yes.
That was another reason I wanted to show you that video so that we could go back and calculate that. Yay. Okay, so an LGA baby can, again, be any gestation, but they're greater than the 90th percentile, like based on that, the graph I just showed you. And macrosomia would be greater than 4,000 grams. That would be the term for that. And then small for gestational age, SGA, again, any gestation, but less than the 10th percentile. Right off that graph. And then there was an objective that talked about intrauterine growth restriction. So it used to be intrauterine growth retardation. We tend to not use that word anymore. So intrauterine growth restriction. So this would be something, it'd be the baby didn't grow correctly because of genetic or environmental factors. The LGA, SGA, we're not really sure necessarily why that might have happened, but generally speaking, the intrauterine growth restriction is due to some cause. Their potential is just not reached. So for LGA babies, assessment and problems that you'll see, sometimes large parents, weight gain in pregnancy, diabetes, right? That's one of the have you, anybody taken care of a baby born to a diabetic mom?
Yes.
Liz, you've done it all.
I've had good babies.
And what do those babies look like? They look swollen. They look like the Stay Puft Marshmallow Man or the Michelin guy.
Baby was just, yeah, it looked really like, it almost like it had edema. It was just really,
yes.
really swollen.
And it is, there is edema, yes. And if there's a history of LGA babies. And so we talked about the shoulder dystocia, which can lead to a fracture like a clavicle. There could be nerve damage. The brachial plexus is there. You're going to see the hypoglycemia and polycythemia. What's polycythemia?
High hemoglobin and hematocrit.
Yes, Sonia, very good. Right? So they might look ruddy. They might have that redness to them. And then we're going to talk about TTN, which is transient tachypnea. And we already talked about respiratory distress syndrome. And then if we're looking at small for gestational age, problems that you might see, again, could be diabetes, but more advanced diabetes, if the mom had an infection or anemia, chronic kidney disease. Babies in the video, the mom had PIH, high blood pressure, pregnancy-induced hypertension, and this was an SGA baby. See the connection there? Yay. Okay. I just get excited when things connect like that. Sorry. And it is Friday, so substance abuse. Sometimes the neonatal abstinence syndrome babies are smaller. If it's an abruption or previa, chromosomal abnormalities. And then this is just, again, look at the list. Look, respiratory distress, hypoglycemia, right? Decreased oxygen levels. So these are really the things that we're focusing on with babies. And then this would be McRoberts maneuver here with the legs back and the suprapubic pressure to try and get the large baby under that bone. Because see where the shoulder is there? And so as you pull, right, you want to be able to get the shoulder out. And that's why you use McRoberts maneuver. So monitoring vital signs, monitoring the O2 levels, monitoring bilirubin, maybe needing help with supplemental feedings, checking the neuromuscular status. One of the things you'll notice when you're looking at the baby, when you're looking at the arms, like if there was a shoulder problem, they'll move one arm, but they won't really move the other arm. So you want to look for bilateral symmetry. Does that make sense? Yeah?
Yes.
Because that's how nurses catch it a lot. Everything's fine, and mom's holding the baby's not really crying. Not in a bad way, like they're not crying in pain kind of type thing. And then we take the baby after they've done skin to skin for an hour. We take them to the warmer to, dry them off and do whatever. And then we notice that the arm isn't really moving or has way less mobility than the other. And then we check and maybe there's crepitus, right? That cracking kind of thing. And so then we call the doctor and they do x-rays and all kinds of stuff. So that's why the assessment, again, is so important. And then other complications that might be seen. So this is a picture of a diaphragmatic hernia. Again, a congenital defect. So your diaphragm normally here on the left. And then there's actually a hernia, an opening. And so the intestine is coming up into the breathing space, which is not good. Can you see the difference in the lung size? Like this one's a little bit small. I know it kind of looks smaller over here too, but what happens is that intestine sort of takes over that space and the lung can't grow. And if the lung doesn't grow, then there's less alveoli. And if we have less alveoli,
less gas exchange.
Yes, yay. I mean, not yay, but yes. So when they're born, it might not be something that you notice right away or that got picked up on ultrasound, but they're going to have trouble breathing. They're going to be tachypnic. They're probably going to have some cyanosis. And what you're going to notice is that the chest, one side's larger than the other. That's a big giveaway. And then the abdomen is like concave, like it's sunken in. Right? Because where is it? It's up in the chest, which is why that side's larger than the other. And so that's a medical emergency. They usually take them to surgery once they figure that out. RH incompatibility. Have y'all talked about like RH and RhoGAM and? Yeah, kind of, right? And so it's basically the antibodies are, the mom gets sensitized and the antibodies are actually fighting the baby. That's not good. And then another type of incompatibility would be the ABO, the blood type AB, ABO type, and the baby has a different type. And so the mom's body kind of starts fighting against the baby's body. And that's another term for that is hemolytic disease of the newborn. So reasons that you could have that are listed on the left-hand side: amnios, bleeding, miscarriage. And then you're going to do the RH, the RhoGAM, right, during the first pregnancy to prevent that from happening in subsequent pregnancies. So usually, is this what you're seeing or hearing is the 28th week of pregnancy, and then how long after giving birth? Anybody seeing RhoGAM or history of?
So my friend actually got RhoGAM because she was, it was her third pregnancy. Well, she got it on the second one too. So
yes.
she was telling me that she got it after she gave birth
Mm-hmm.
for the first one.
Okay, there you go. Right, so that's really important because what can happen is something called erythroblastosis fetalis, say that 3 times fast, and that can lead to problems with the baby. And so this actually is, I think, Desiree, you were looking at the article that was talking about the high drops. And so the baby can develop the larger liver or spleen. There's edema. They can be jaundiced. The high drops, which is where the fluid starts to accumulate in spaces where it's not supposed to be. So this is showing you the swelling. And a lot of times the face is a lot more swollen than that. If you know this is going to happen, you can deliver the baby early. I think they're actually able to do, I mean, it's on the slide, I've not seen it done, but intrauterine blood transfusions, like the things you can do in utero now is just amazing. But again, that's a scary situation. You would hopefully know about that prior to the baby being born. Obviously, if you can do blood transfusions in utero. So hopefully those things can be you know, you can fix those somewhat. Okay, so what I'm going to do with the respiratory complications, because we have like 8 minutes, oh, 7, oops. But what you're going to see is that it's all kind of the same thing, right? That we've been talking about all today, right? With infants, it's more like if they're going to code, if you will, it's a respiratory problem. Whereas in an adult, it's what kind of problem? Heart, right? So this is all, you know, babies, if you can get them breathing half the time, more than half the time, that will help the perfusion. So that's why you're always working on the respiratory status. So we're going to do breakout groups, but we don't have time for that. Sorry. So we've already kind of talked about from the video though, which I think, you know, what assessments, right? So what would a priority assessment be for a newborn? What are you looking at with a newborn with a respiratory condition, regardless of what it is?
Airway clearance.
Yeah, airway, you know, clearance. Can they move air?
Color.
Their color. What else?
Breathing pattern.
The breathing pattern. And so what would, you know, you're gonna look at their oxygen saturation, you're gonna look at their work of breathing, if there's retractions, and then what goals do you want for your newborn, your neonate? Come on, I know you know this. We're talking respiratory.
Breathings to be between 30 and 60.
Right? You don't want them tachypnic and you don't want them apneic, right? So you want that, your assessment is their breathing pattern or their rate, and your goal is that it's going to be 30 to 60. What else?
Oxygen saturation.
Oxygen saturation. Where do you want the oxygen saturation to be?
90.
Order, generally above 92 is acceptable. In premature infants, maybe even 90, but 92, but you don't want it to be, if they're on oxygen especially, you don't want it to be 100%, because then they're probably getting too much oxygen, and we don't want them to have eye problems. So generally, if you can keep it between like 92 to 98, 99, you're good. And then, so interventions, what are things that you can do to get your patient to that goal?
Administer oxygen.
Administer oxygen, right? Nasal cannula, high flow, position them.
Suction.
Yep. Yeah, position, so you can prone them, you can turn them on their sides, whatever position helps them breathe better.
Suction them if needed.
Suction them if needed.
Cluster care to decrease stress.
Yes, nice, good. And then what are you going to evaluate?
Skin color.
Well, go back to you're going to do that, but go back to your goals. What was your goal for the patient?
Oxygen saturation.
The oxygen saturation, so that's what you're evaluating, right? If the oxygen saturation is 97%, did the patient meet the goal? Yes. It's that simple to bring it around. So let me just give you some key points for these different things. So pulmonary hypoplasia, basically this is a congenital thing where there's fewer air sacs. That's just the way the baby's born. It's a chronic lung disease. And there's also less surfactant. So these babies are really, really sick. They're going to need the ECMO, which is extracorporeal membranous oxygenation. Basically, it's a heart-lung bypass machine that breathes for them so that they can fix things and hopefully get things the way they're supposed to be. And then they're not going to really be able to eat, so they could be failure to thrive. They could have developmental delays. But the key thing is that it's a congenital chronic lung disease. Asphyxia, anybody been at a delivery with a nuchal cord?
No.
Yeah, you have to, because there's way more nuchal cords than I ever thought there would be. Or cord compression, right? You're looking at the strip, the monitor strip, and they say, oh, I bet the cord's being compressed because of the way the decels or the way the pattern looks, right? And so that's asphyxia. There's actually primary and secondary, which is what you would need to know, is that primary, they'll get an increased respiratory rate, so they'll be kind of looking okay, and then they kind of stop breathing. There's no respirations, or it decreases, the rate decreases. You might see some grunting, but if you stimulate them and you give them a little supplemental oxygen, they're good. Secondary apnea would be where the baby, where the oxygen decreases. You may see a loss of consciousness, and you try to stimulate, and it's not really effective. And so then you have to go to potentially positive pressure, so bagging the baby. And again, you might see this from narcotics given, from the cord compression or a nuchal cord. So does that make sense? So this is a primary, you can stimulate them, oxygen helps, they come back, they're good. This one would be more with a nuchal cord or some other like cord compression, and stimulating isn't like in the video, right? They stimulated for a while, didn't really work that great, so they bagged the baby. And then things were better. Key points for transient tachypnea, TTN. So this is often seen in larger babies, LGA babies, diabetic babies. And when I say diabetic, I mean diabetic baby of a diabetic mom. And so there's fluid that just doesn't get absorbed. And so it's difficult for them to breathe. They don't start out with tachypnea. It develops after a couple hours. And then there might be grunting and flaring, and they'll do x-rays, and it will look, I couldn't tell you, I'm not an x-ray expert, but it will look like what they call TTN. And what normally happens is they'll put them on some antibiotics. It's amazing to watch this. It takes about 3 days for this to resolve. And then the baby who's been on they diurese, like they just pee and pee and pee, and their breathing comes down, and it's great. But it's really interesting to watch it happen. So they're going to do the x-rays, resolved by the 3rd day. There you go. Meconium aspiration, MAS. So I don't know if you can see, but right here, it's kind of golden yellowish right there. And the baby kind of has that, you can see the color. So that baby's been swimming in some meconium there. And so rapid breathing, retractions, grunting. So same things, right? Same focused respiratory assessment that you're going to see. And so this baby probably was not breathing, which is why they're bagging. Oftentimes we'll have intubation equipment available for the physician in case the baby's not breathing. I have like 3 more slides to go, but you're welcome to leave if you would like to. So suction, you can do the ET tube, oxygen, and these babies will be in the NICU on antibiotics because instead of air, like there's this, right? You've seen meconium, right? Imagine that in lungs, right? That's just gross. And the lungs can't inflate, the alveoli can't inflate. Yep, we talked about that, usually within 3 days after birth. For the, I'm sorry, persistent. So PPHN is another set of initials. So this is one that you don't see. It can present a couple days after birth. And so you get this high blood pressure built up in the arteries. And so remember in adults, right to left shunting. And so this baby has this hypertension that doesn't go away. And that can be obviously dangerous to the baby. So risk factors, infection, hypothermia. A lot of times it's congenital disorders, things where it's underdeveloped lungs, like the hypoplasia. And then again, right, pattern. Hope you're seeing a pattern here. Rapid breathing, the grunting, retraction, cyanosis, right? And then potentially, because there's a cardiac component, because it's persistent hypertension, you're going to see low blood pressure, edema, heart murmurs, that kind of thing. So blood pressure medications, antibiotics, surfactant to help try and open up the lungs. So we're hearing a lot about surfactant. And then oftentimes they're on ventilators. They might be getting continuous positive airway pressure. anything you can do to help the oxygen levels and keep the, you know, keep the baby calm and try and get them to a normal blood pressure. So, and then anybody that's interested, I had slides for, or information for the NRP programs, the neonatal resuscitation. So again, when I tell you guys do your safety checks, right, make sure the suction's there, make sure if you know it's a premature infant, right, have the intubation equipment ready, have the oxygen ready to go. If they need to do umbilical artery or vein catheters, that's how they can do IVs right into the umbilical cord, right? Because there's how many arteries and veins in the umbilical cord?
2 arteries, 1 vein.
Yes, Ava, thank you. Good job. Not Eva, but like AVA, Ava. Right, good. And then epi. We don't really even give Narcan all that much anymore, or bicarb or anything. Epi. And why did that not go? There we go. So, whoops, my bad. On your own time, certainly you can look at these videos. This is disorganized, and these are on YouTube, so you can find them on YouTube to find the sound. But this is a poorly run code, neonatal code, and this is a well-run neonatal code. So again, like SIM, it'd be nice for you to compare the two. This is the book. This will take you to the flow chart for the NRP guidelines. And then does anybody have any questions? Because otherwise I'll leave the video up and see you guys in CRS.
See you, Ms. Sandra.
Thank you, Ms.
Alrighty.
Salinger.
Thank you.
Bye.
Bye. Again, this one is on, video's unavailable. Well, find it on YouTube. Thanks, everybody. Questions? I'll take questions. Bye.
Bye.
Valerie's giving me a thumbs up. Yay. Jessica's clapping. Bye.
Salinger.
Yes, hi.
Sorry, I have a quick question.
Yeah.
Yeah, it's not about the class. It's about, I want everybody to go out to the question.
You what?
And it's about the CRS.
Okay.
Yeah, so I wanted to ask, as in to start the class, is it okay if I ask like a question about if they can differentiate between immunization, vaccination, and inoculation? Or should I just like, because I looked at it, I was like, maybe I'm going off topic, or should I just go straight to the point and just deal with the pro, con of
I mean, if whatever you want to do, if you want to ask a question, that's fine.
Okay.
To get people thinking about it, yeah.
Yeah, because I'm confused. So I'm like, okay, like I googled it and I was like, I think vaccination is the same thing as immunization.
Yes, vaccination and immunizations are the same.
What about inoculation?
Yeah, we just don't really use that term anymore. But inoculation was, we used to use that.
The 3 of them, they're the same thing?
Pretty much, yes.
Oh,
they're interchangeable.
Okay, so let me know.
So the vaccine would be what you're administering, right? And the immunization would be the process.
The process of getting it.
Yes, and then that's the same with inoculation. It was just a way that they did it.
Okay, I'm good now.
Okay, that's all good.
Okay, thank you.
Okay, thank you.
Yes, CRS. Bye.
Yep, bye. Hello. That I don't care about.